Welcome to The Pulse, the official podcast of the Georgia State Medical Association.
Well, hello, everyone. Thank you. Thank you for joining in. First and foremost, welcome to The Pulse. My name is Dr. Julianne Adams-Burt. I am serving several roles tonight. I am hosting this evening's discussion. I am also the president of the Georgia State Medical Association, and I am a board certified obstetrician and gynecologist who no longer delivers the babies, but I am lending my voice, have been lending my voice all this week because this is Black Maternal Health Week. And I wanted to have this conversation with some folks who are on the front line, continuing to do the work in both areas that encompass women's health. And so I am so honored that the ladies that I will introduce to you now were able to clear their calendars. They are busy, but they were able to give us some time. So first up, I want to introduce and welcome none other than Dr. Keisha Renee Callens. She is, as I said, also an OBGYN, and she is a public health leader. She has over 20 years of excellent experience serving both rural and underserved communities right here in Georgia. She practices with Community Health Care Systems, Inc., where she also serves as Chief Wellness Officer, delivering critical reproductive care in maternity care deserts. Dr. Callens is a professor in the Department of Community Medicine at Mercer University School of Medicine, is dedicated to educating and mentoring future healthcare professionals. She has so many mentees that look up to her. She hails from University of Virginia with her BS in biology, and then she went to UAB and got her master's in public health. And then she went to my alma mater of Morehouse School of Medicine. I'm older than her, y'all. She is a respected leader and speaker and is widely recognized for her commitment to advancing health equity and improving community health outcomes through service at the local, state, and national level. So welcome, Dr. Callens. Greet the people.
Thank you. Excited to be here.
And we also have her sidekick. I'm going to call her a sidekick. They don't work together, y'all, but they're such a fabulous duo. I am so honored that they were both able to clear their calendar. So I would love to introduce Dr. L. Joy Baker, also a board certified general OBGYN in LaGrange, Georgia. She has worked in both urban and rural communities for over 15 years. Again, hailing from my alma mater, a little biased, I know, the wonderful Morehouse School of Medicine, and she did residency not only with Morehouse, but in the Grady Health System. She currently serves as Director for Quality and Safety for Women's Health and is Vice Chair of the Department of OBGYN and Pediatrics at WellStar West Georgia Medical Center. She is one of the first physicians in the United States to complete a HRSA Fellowship in Transformational Healthcare Leadership at Morehouse School of Medicine. Devoted to servant leadership since her matriculation at LaGrange College, Dr. Baker was selected to the American College of OBGYN's prestigious Cephalo, did I say that right? Cephalo National Leadership Institute. Is that it?
Yes.
Thank you. And Medical Association of Georgia's Physician Leadership Academy, earning her recognition as a Georgia Trends top doc in the OBGYN division. In 2024, Dr. Baker was named WellStar West Georgia's Physician of the Year. Now, we already know she's live, but they know it too. So Dr. Baker holds special certification in perinatal mental health as well as treatment and addiction in pregnancy. She is designated as a surgeon of excellence in robotic and minimally invasive gynecologic surgery by the SRC. Clinical and research interests include, there's a theme here, y'all, health equity, and why we wanted her here so badly, reduction of maternal morbidity mortality, statewide perinatal quality improvement, and minimally invasive GYN surgery. She speaks all over, y'all. She's launched her Delivering Joy, as you see by her tag there, on social media platforms, and she is a wealth of information and a reliable wealth of information, y'all. I tell folks that I started, once I became president of GSMA, this podcast because I wanted our audience members to be able to rely on the information that they were getting and not just go on a TikTok and count how many, followers a certain TikTok influencer had. I wanted us to be able to spread the information to our community. So welcome, Dr. Joy Baker, Dr. Keisha Collins. We are going to dive in. All right. So as I shared, this is Black Maternal Health Week. And all this week, I, on my own podcast, on my own platforms, have been sharing little tidbits here and there. Starting off talking to those who would take time to read it, I started sharing about preparing oneself for pregnancy. We've got to start with the basics, and we want to encourage our moms and those who wish to become mothers. We want to explain to them first and foremost, what does it mean to optimize one's health, and why is that important? Dr. Collins, can you share, please?
Absolutely. I'm so glad that you invited us to join you today, and I'm happy to celebrate this week and to end with this podcast. But it just
I
so
think you're
happens.
muted, Dr. Collins.
What'd you say, Dr. Joy?
I think she's muted. Like
No,
she's talking, but
we've
you
got.
can hear. I can't hear her.
You
I
can't
can't hear her.
hear.
Oh
Can we
Lord.
get the production team in the back to fix that?
I was like,
No,
I'm not.
it's
I
okay.
don't
I can
think
hear
I'm
you
muted.
just fine, loud and clear, but I cannot hear
Okay.
her. But
Can you
anyway,
hear
we'll
me?
be quiet.
Can you hear me now? No.
We can hear her. The
Okay.
producer says she can hear her too. Uh-oh, Dr. Joy.
This is weird.
That is weird. All right, we try to fix it. Go ahead, Dr.
Well,
Keisha.
well, it's okay if we're duplicative because it'll just reinforce what we have to say. But I'm
Yeah.
so happy that you started off the conversation with talking about preconception care. I actually spoke at the Three Rivers AHEC Maternal Health Symposium in Statesboro this morning, and I had a chance to be the first speaker, and my topic was preconception care as a strategic intervention for improving maternal health outcomes. And so you might be psychic. I don't know.
I really did not know that. I did not have your agenda from this morning, but take it
So I
away. Take
literally
it away.
drove back from Statesboro, and so we're doing this. So really, I was able to do a little demo, and I did a prop this morning that I think resonated well. And I talked about how planning for pregnancy is like planning for a trip. It's like packing your suitcase. And so I brought 2 suitcases with me. The first one was empty, and I literally said, if we are not talking to patients about preconception health and optimizing pregnancy, then they're going to the beach with an empty suitcase, which is not cool. You don't have your cute flip-flops, you don't have what you need, you don't have your sunscreen, you don't have your hat, not the way we want to do it. And so ideally, we want to have an opportunity to make sure our moms are taking prenatal vitamins before pregnancy. We want to make sure if they have any chronic conditions like high blood pressure, diabetes, we're able to get those things under control to reduce the risk of effects to mom, but also any harmful effects that might happen to baby, like in diabetes, you can have, birth defects. And so it really just gives us a chance to really help moms step into the pregnancy the proper way. But I'm going to take it a step further because I'm realizing now Number one, that preconception talk is not just for mom, it's for the couple. A lot of times we leave our dads out, 50% of the DNA. And so if mom is a smoker and dad is a smoker, we want them both to quit smoking. So our counseling needs to really be both. But also, it's not just focused on the pregnancy. We want to make sure we have healthy parents. And so instilling healthy behaviors at the onset of pregnancy is something we hope to use to inspire them to continue that, to change their behavior so they can be healthy parents to take care of the kids that they will have for their lifetime. So I'm going to hand it back to you with that.
I love that. I love the suitcase analogy. Dude, I would note that and put that back to use in a future talk myself. I love that. So,
If I could jump in, I would love
sure.
to just add a little something. I had an opportunity to do a preconception health talk, and we talked about a framework. We talked about, you know, Dr. Callis mentioned healthy family. That's very important. We talked about the physical, the mental, emotional, financial, relational,
Mhm.
um, spiritual preparation for becoming parents, and it is holistic. And the financial piece is also a big part. We were looking at a study that was about 10 years old at that conference, but it said that it costs upwards of nearly $300,000, and that was in 2015, to raise a child from beginning to end.
Ooh.
So,
There is no end.
Right. There is no end there because I'm 45 and I still will hit my daddy up. I hit him up for dinner the other night. So, it does. There is a cost, a physical and emotional and mental, financial, relational cost. And so
Mhm,
making sure that you're with the partner that you want to parent with, making sure that you have, one of the things you have to think about, pregnancy is completely unpredictable. So what happens to your family if you end up on bed rest for 3 or 4 months and you're not able to
mhm,
continue working throughout your pregnancy? So there's so many things to consider, and obviously you can't plan for everything, but it's so
mhm,
good to put some thought forward, because a lot of times a little bit of thought in advance and optimizing not only your physical and mental health, but your financial health, the health of your home, it can really reduce a lot of stress during the
mhm.
pregnancy. The pregnancy is stressful enough on the body, on the
Right.
mind. So whatever you can do to sort of mitigate some of those risk factors is so important.
To the point which you're speaking to, it makes me think. I was listening to a lecture, maybe a podcast the other day, and they were talking about social determinants of health, right? And that phraseology came out, in the 1980s, I think. And people don't think about all of those things, right?
Right.
And I'm just going to talk about my own upbringing because it didn't hit me until probably adulthood. My home literally was across the street. Now we saw woods on the opposite side of the street where I lived, but there was an incinerator. So,
Mm,
and I was born into that home and lived in that home until the age of 18. So now that we know more, educating our patients, our potential moms about where you're going to live, neighborhoods, right? Are your neighborhoods near? I learned this from Dr. Callens when she joined us on another podcast. So, is your home situated near a
Superfund.
freeway, right?
Or
Are you inhaling, the smoke from these cars on 285, 75, 85? Just all the different aspects of it. I What you just shared is, I don't think it is out of the realm of possibility for people to really consider. We think probably too late about where we're situating our home when we're raising the kids, but even in the pregnancy, being able to have fresh fruits and vegetables at your disposal, or are you having to go across to the other clear side of the other side of town in order to purchase
hmm
healthy choices? But
hmm
let me ask this. And either one of you can chime in, what are three things every woman should never ignore during pregnancy. Three things that she should never ignore during her pregnancy. Go ahead, take it away.
All right, Jen.
I'm going to say number one, her intuition.
I love it.
If you have the thought that something is wrong, something is off, that something is happening with your body or your baby, or your birthing experience, don't ignore that. And then, of course, we don't want to ignore the important vital signs, like if your blood pressure is high, your heart rate is abnormal. These are things that should not be happening. Pregnancy puts tremendous stress on the body, right? The heart, we call it a stress test for the heart
Mm-hmm.
because of the increase of the amount of fluids that are running through your body. The heart has to work much harder.
Mm-hmm.
And then because of the expanding uterus, the pregnancy, the baby is growing, it can make it a little bit more difficult for you to have a lot of oxygen reserve. So there's lots of things. If your vital signs are abnormal, you should definitely address that as well. And certainly, if you're having mental health issues, so I think that's a huge thing we don't talk about a whole lot, but actually. Substance use and mental health disorders are the number one cause of death in the United States. It's 23%. So those are three things that I counsel my patients, like, don't ignore that. If you're struggling mentally, emotionally, if your vital signs are abnormal, or if you just know something is wrong, don't
Mm-hmm.
stop until you can get some answers.
Mm-hmm.
I think that's fantastic. I'm gonna add a little bit more to that. So I'm gonna do
Uh-huh.
my three because I'm gonna complement what Joy said. If you have a headache, blurry vision, things just don't feel right. You sleep, you take Tylenol, and your headache is still present. You need to go in and have that evaluated. And I tell my patients all the time, I would much rather you come in and we check you out and you're fine and you go home than you stay home and then have a problem and then we say woulda, shoulda, coulda. So I don't. I want people to come in, get that reassurance, and then we can discharge if that's the case. The other thing is, if you are having any pain, so you might have pain and you're thinking, oh, I might be having Braxton Hicks. They may just be normal with pregnancy. But if it's persistent and you're concerned, you're feeling pressure in the pelvic area, you're leaking any fluid, seeing any signs of bleeding, don't hesitate as well to come in. And the last point I'll make is, and I've seen this happen where the baby doesn't move very well.
Mm.
And patients are like, I'll just wait and I'll just go in tomorrow.
Yeah.
And sometimes by the time you first realize it, there's already a process that's going in. And
Mm-hmm.
so the time it takes you to wait and see and then come to the hospital and then have us do our emergency efforts, which may or may not be successful, is time lost. And
Yes.
in pregnancy and in labor, and we all know this because we've all delivered, a second can feel like a minute or longer. And so that's how I think about time. And so really, I love what Joy said is follow your intuition. If something does not feel right, come in, have us evaluate you. And if it's fine, it's fine. But reassurance goes a long way.
Yep.
Absolutely.
Yep. Someone jump in and speak to us about the importance of it. First of all, for those of us who are on here listening, if you're listening to the replay, we are all in the state of Georgia. Georgia has 159 counties, and I think to date we're missing out of those counties, and some are kind of on top of each other, but there are 82 counties that do not have one OBGYN in their within their zip codes or whatnot. So everyone may not be able to have this opportunity, but speak to those who can when they're deciding on who to trust with their care. Just highlight some things that they should be thinking about. When you're choosing an obstetrician or you're choosing a midwifery group, how do you choose? Do you choose because it's the closest one, right next door, or, it's next to the
I,
hospital?
I'm gonna say I have been all week listening to all kinds of podcasts and shows, and sometimes, and this is really sad, we will research our hairstylist more than we research our OB care team. We want to read all the reviews, want to see all the Instagram pictures. We want to look through all of it to see, like, is this who I want to do my braids? Right. But we might just take the closest OB or midwife or, the closest place we can go, the most convenient place. And we're not really necessarily putting all that emphasis on one of the most important things that's going to happen to us during our pregnancy, our birth, postpartum period. um, First of all, I would say be practical, understand a preconception visit goes a long way. So if you're thinking about becoming pregnant, visit with someone, an OBGYN or a midwife who does GYN care, just to get your well woman assessment. Make sure that you're healthy, make sure that you have opportunity to optimize your health. And then get a feel from that individual. Like, is this somebody that I would trust to walk through pregnancy with me and walk through postpartum with me? And then, be practical. Midwives are magical. I say that all the time. But if you're someone who has diabetes and hypertension and sleep apnea and asthma and a lot of chronic medical conditions, midwives are trained in physiologic pregnancy, birth, and postpartum. And so you might want to select, a physician for your care, or at least a midwife who's practicing with a physician in the office so that you can be co-managed. And you may even need a maternal fetal medicine specialist as well.
Mm-hmm.
So, you want to kind of, that preconception visit really helps you estimate what your risk may be, and that can help you really decide who you need on your team.
Right.
um, we've been talking a lot in Georgia, in the legislature lately, about midwives becoming independent, working on their own without collaboration from a physician. And, the issue with that is not that midwives are not trained and they can't handle birth or pregnancy, but what happens when those medical complications come, or if there's an emergency and a surgical intervention is needed. So there's so much that sort of goes into that. And I
Mm-hmm.
think that the OB care team is just that. It's a team. It's your OB physician, it's your midwife, it's your doula, it's your social workers, it's your nurses. We need as care navigators, peer supporters. We need everybody to wrap supports around this person and this family.
Absolutely.
So I always say, like, kind of be practical, figure out what your risk. If you have a very low risk pregnancy, midwife is absolutely appropriate for you, and probably even better for you.
Right.
Because we know that midwifery care can improve outcomes for low risk women. So I think that we just kind of have to be mindful of what we're trying to do. So
Right.
dive into your OB care team the way you diving into these hairstylists and
Or
nail
your nails, or
nail techs and makeup artists, right?
yeah.
Right? Because I
And
mean, I'm crazy about my glam squad too, but
glam squad, I love it. But
yeah, but
the other piece that I share with my patients, because all of them who are successful in conceiving, I do, of course, refer out. I say, don't just choose, I mean, what you just said, research, but choose who you gel with. That's for any
Mhm.
primary care, OBGYN, but also know if their protocols work for you. So if it is Saturday night at 8 p.m., who you gonna call? Who answers you? Does that work for you? If you go to a bigger hospital, because you heard that that was the best hospital to deliver at 5:01, who's gonna be there for you? Are you okay with that? Just understanding all of the nuances of that, the delivery team, the OB care team is important. And a lot of them do a great job of offering that information up front. This is who you're going to speak to in the midnight hour if you have to call, or this may be who you're going to be delivered by. I would also, and I've been sharing this too, it's been several years. I think one of you may be able to correct me, 2019, when the time frame of when the postpartum visits are recommended. See, I haven't delivered since 2019. That's why I'm a little shaky on that. But the follow-up care, because the one thing that we want to impress upon our audience members is that, when we are speaking of Black maternal morbidity and mortality, sometimes it's near misses, and sometimes, unfortunately, that there are moms who just do not survive. 3 to 4 times more likely, Black women are to not um, survive, not just childbirth, um, but also pregnancy, but childbirth and up to a year after, right? So, of course, I'm thinking about all the celebrity names, but how many women are unnamed that we do not have a story to add to? But anywho, I think it's just important when you're researching to research all the things. And I love that you say you got to be practical too. Like, I don't want you traveling 2 hours to receive your care. Dr. Keisha, you want to
Yes,
add?
I wanted to add in a little bit to that too. So I actually ask my patients to, while they're doing that research, think about who their pediatrician is going to be, because you're going to spend a lot of time
Mhm.
with your baby. They're going to get sick. They're going to get an ear infection. And what I want people not to do is to just randomly pick someone, because you're going to spend a lot of time in that office. And if you don't like them, it is going to be a problem. So when I was selecting my pediatrician, she opened at 6 a.m. They had evening hours. I mean, I was like, I could go to work, I take the kids and then go to work. And so that was looking at what's convenient for you. Do they have Saturday hours?
Mhm.
Who's covering? And so I want to loop in the pediatrician research as well with the OB research. I also want to pick up on something that Joy mentioned, Dr. Joy, about selecting and having that preconception visit beforehand. Because what happens a lot of times is, the first 12 weeks of pregnancy can be a little shaky. You may have some spotting, you have some pain, you have some bleeding, you go to the ER, but they're not OBGYNs. So you're in this like twilight zone. So the advantage of establishing a connection with a clinician ahead of time is when you have a problem, you have a person to call. You're not just popping into the ER every 48 hours to get repeat blood work and nobody's really telling you what's going on. You don't know when you're going to get an ultrasound. And so I think, again, going back to how we step into the pregnancy, doing the research early, seeing them, I want you to be able to deliver, and then having that relationship building early is very important. The other
Yeah.
thing is expectation. So we have the way practice models are now, the person that you see for your prenatal visits may not be the person that delivers you. And so you want to figure out who's in that practice. So you
Right.
scroll and look at all of the people who's going to be on call. What's their schedule? How does that work? And it would be ideal if you could meet most of the people in the practice during the pregnancy. So that way it's not a stranger. And that's why I think having our complements of the care team, like having a doula available or a midwife, is so helpful, because sometimes that care is more consistent. And so when you're in the room, even if it's someone you've never met, you do have someone that you know that's with you. And that helps with some of that anxiety. And so just really being very thoughtful. So we don't want to happen into any of this if we can. We
Right.
want to be able to make that relationship early. And so I just wanted to add those points to the
Yeah.
conversation as well.
And both of you have used the term doula, and I was on a panel last month, and there was a doula who is on staff, and I learned that Wellstar is the first to employ doulas. Could you please explain doulas in general, and then kind of give us a little, pub for what Wellstar is doing and what you think, the rest of the country really should be using them as a model for.
Yes, absolutely. So the word doula actually means one who serves. And that's actually what that means. And so there are all kinds of doulas. There are, hospice or end of life doulas. There are doulas for pregnancy, birth, postpartum. And at Wellstar, we have a doula. We actually employ doulas, and we have a whole team of doulas. And so our patients who would like to have a doula are able to have one. So that has been a phenomenal change over the past 2 years. For my practice, my experience has just been amazing. And I know that there kind of exists a little bit of tension sometimes between the OB care team and the doula. And so the doula is usually a certified childbirth educator. They are there for mental and emotional support. They can also help patients sort of advocate for themselves. They do a ton of education with patients about the pregnancy, birth, and postpartum process, and they're really there to care for the whole family. Just recently, we were doing a simulation in my hospital because we do them every quarter. Like if we're managing postpartum hemorrhage or hypertensive disorders of pregnancy, we kind of practice those really high risk, rare things that can happen on labor and delivery so that when they do happen, we're ready. Like we say, if you stay ready, you ain't got to get ready. So we practice together as a team, everybody. We call it overhead. The anesthesiologist comes, the pharmacist comes, all the people from the blood bank. It's a really neat thing to see. But for the first time a couple of months ago, we had a doula that was present. And we didn't realize that we needed someone in that role, but while the team is so focused on making sure that this mom goes home with a good outcome, the doula was just sort of in the patient's ear, whispering to her, explaining things, holding her baby while we work on this postpartum hemorrhage, like just doing, all these things that we
Mhm.
may sometimes be too focused on trying to prevent badness to do for the patient, and just sort of helping to ground that patient and be there. And so that's one of the things I really appreciate about our doulas. At my site, my doula's come into the OR. So while that mom, she was not expecting to have a C-section and she has to get a spinal anesthesia or whatever's happening, they're there to just all they do is just hold her hand, put a blanket on her, that kind of thing. And that's something that we didn't really realize was such a big deal until we started to understand that traumatic birth experiences have very high rates of postpartum PTSD,
Mhm.
depression, and anxiety. And
Yes.
so I feel like there is certainly a role there. The doulas actually make my job a lot easier. And I can tell you a brief story from a doula who came and took a patient to the ER postpartum who had severe preeclampsia and preeclampsia induced heart failure. And she called her supervisor and said, "I need to get in touch with Dr. Baker because I think this patient needs to have a cardiac workup, and I'm having trouble sort of advocating for that and the ER." And so the supervisor called me. I was able to talk with the ER doc, and lo and behold, this doula who's had training on, on cardio obstetrics was like, "Oh, she needs a B&P." So we got that. And sure enough, she had peripartum cardiomyopathy. So
Yeah.
they sort of stand in the gap because we see them in the office, we see them in the hospital, but they're visiting their homes, they're talking to them, they're spending time with the entire family. They're a fantastic bridge.
Hmm.
And I'll just add that, post pregnancy loss doulas are also extremely important because not
Yes.
all of our pregnancies end the way that we would like them to.
Right.
And so again, it's that emotional support bridge that allows them to have that connection because those are patients who are experiencing grief need support just like a new mom does.
Hmm.
And so that's really important. And I wanted to also go back to something you mentioned earlier, Dr. Julianne, about the timing for the postpartum follow-up. So now we actually are looking at 3 weeks is the new standard. And that needs to
Okay.
happen in some shape or form. It could be in person, it could be, virtual, so to speak. But the whole 6 week misnomer, we're trying to do away with that. And ideally, just like how we want our babies to be in the pediatrician's office within the first 5 days, mom needs to be checked also within the first few days because a lot
Right.
of the postpartum preeclampsia, they may have been fine when they left the hospital and
Right.
then they're not fine. And that not fine can accelerate, right, Joy? I mean, you
Oh
can go
yeah.
from okay to like 48 hours. They're in the position that that patient was in. And so we're really trying to adopt the philosophy of out of hospital does not mean out of mind or out of sight.
Right.
And so who is it that is able to help us with that? And a lot of times the doula is able to do that, and able to then communicate with the team just like that happened. And that's ideal. So what we want is to embrace the team and all the parts. And what we want is any maternal life that we lose is too many.
Right.
So whatever we have to do in terms of connecting the dots to make sure that that communication happens, that is what we're striving for. That's our vision board for the ideal scenario for our moms.
Yeah. And so that reminds me of Dr. Irving, the CDC epidemiologist, who she was a researcher. She was, she knew warning signs, and sounds like the panel that I was on last month, her mother was there and her daughter was there. And it just breaks your heart that someone who knew the signs and kept going back. She was going, I believe, to the emergency room, or at least to her doctor's office, and was in my opinion, I have not looked at the whole chart or anything, but it just sounds like mismanaged, misdiagnosed. So learning all the things that they should look out for, I think, is important, and it's great to hear. I was not aware of like the length of stay for the doulas. I actually trained in Pittsburgh, Allegheny General Hospital, and we had doulas all the time in my training. I graduated medical school 25 years ago. So when I got here to Georgia and stopped seeing so many doulas, I didn't see any doulas in my first practice. And even in my current practice that I started in 2011, I could count on one hand how many women brought doulas with them. So I'm so glad to see the pivot that we have been witnessing. Unfortunately, because we have folks like Dr. Irving, or I think it's been since 2015, Kira Johnson, who most people, if they don't know her name, they know her family. Charles Johnson, her widower, has been just phenomenal in using his grief as a catalyst, not just to keep sharing the stories, but it's a call to action, right? Yes. A call to action for him. And I had an opportunity to be on a stage with him, which was nerve-wracking. And because my heart just broke, right? Ladies, I'm just going to ask you to not to share any details of because of HIPAA, right? But I tell audiences often, every OBGYN I know probably suffers from a little PTSD. They always have that one situation, that one case. But when I heard about her story, and I'm like, who and how are we looking at a bag filling with blood and not responding? So when we talk about research, sometimes you will find, and there's always there may be bad outcomes. And I don't mean take one story and run with it, but if someone has repetitive concerns out there in the public, have more conversation about that. That is so vitally important. Can someone speak to, I mentioned it 3 to 4 times more likely to die before, during, or after childbirth. Can you speak to like the top 3 at least causes? We're kind of discussing them, but just so that moms who are maybe listening in or listen to the replay will be like, whoa, I don't want them to just get nervous. I want them to get educated. So if we could just share with them what are the top causes of those unfortunate deaths.
So Joy, I'm gonna let you go, but then I'm gonna jump in because I want to make sure I qualify that. But go ahead.
Well, when you're talking about statistics, it really can also depend on race and ethnicity. So I mentioned a little bit earlier.
Okay, Joy, we lost your
Did we
screen.
lose her?
And
No, just your screen, but we can hear you though. We can keep rolling.
oh,
Okay.
can you hear me okay?
We hear you fine.
Absolutely.
Okay, great. Because I'm hearing some weirdness. But anyway, suicide and substance overdose are the number one cause across the board, according to the CDC. But that's not necessarily true for Black women. Is cardiovascular disease that's killing us. And so, we have to think about the fact that we often say the system is broken, but the system is actually functioning the way it was designed to function. There is systemic and institutionalized racism, and that's just a full stop, period. But because the fact that this is such systemic racism, there was even just the building of modern gynecology. There was all of this experimentation on Black women. There was sort of this loss of autonomy over our own bodies and our own births and our children. And so, a lot of what we're reckoning with today stems from that historical context, right? But then preeclampsia, we're more likely to develop preeclampsia, which is a condition where your blood pressures get high and your kidneys are not able to hold on to that protein. You're spilling protein into your urine. Preeclampsia can be very serious. People can die from complications of preeclampsia, mainly stroke. So we hear about seizures, but it's actually stroke that has the higher risk of mortality or death. And so, we have to be mindful of who we're taking care of and who we're treating. We talk a lot about why this is true. Why are Black women more likely to die? And certainly, when you think about all of the variables that are at play here, maybe you grew up across from an incinerator where you were inhaling, toxic chemicals. And
Mhm.
then maybe there were no grocery stores in your neighborhood. So you guys ate a lot of processed foods. And so now, by the time you reach childbearing age, you may not be as healthy. Maybe you have already developed high blood pressure or diabetes or some other chronic medical condition that pregnancy, there are very few things that pregnancy makes better in terms of chronic medical conditions. Very few things. Maybe endometriosis, but everything else, if you have heart disease, diabetes, high blood pressure,
Right.
pregnancy is going to make it worse.
Right.
So, these folks are suffering. And then we talk about that whole concept of weathering, like how,
Mm.
we all like to say Black don't crack, but internally, inside of our blood
Yeah.
vessels, our metabolism, all of these things are much more aged in Black women. And it's very interesting because if you look at studies of African people who come to the United States, they generally don't have the same metabolic age as Black people who've lived in the United States their entire life.
Mm-hmm.
But if you leave them here for a decade or so, they
Mm-hmm.
start to develop it. And
There
I
you
think
go.
that just sort of rings the bell that, hey, there's a problem here. There's a problem
Right.
in our country.
Yeah.
So, that I think is really something that we have to be aware of. It doesn't mean we have to live in fear or that we can't stay rooted in working for justice and having joy about our birth. In our family and building our families. But it does mean that we have to be a little bit more aware. We have to be a little bit more thoughtful about what we're doing and how we're interacting with our OB care team and the
Right.
hospitals where we choose to deliver. But I think, when we talk about cardiovascular disease, we talk about, um, also pulmonary embolus, where you get clots in the lungs or the legs, hemorrhage, and
Hemorrhage. Mhm.
serious infection called sepsis is also,
Yep.
some of the things that we think about when we think about the top cause of maternal deaths.
But can I add also
Okay.
too that a lot of the things that we hear in the media tend to be the immediate postpartum losses, okay? But when you look at the timeline over the year, 365 days, the majority of the deaths are happening from 6 weeks to 365. So what does that mean for us? Well, that's one thing. Number two, a lot of those are happening for patients that are upper echelon of age, is what I'm going to say. So 35 and above, okay? I'm not using any of the other terms that we can use, but upper echelon. And so those things are also very important. A lot of times our moms have their baby and they're going back to their regular life. If they have a chronic condition and they're not seeing a primary care physician to address those things, then those are missed opportunities. So truly, if we're losing more of our moms in that later postpartum year, then are they in the proper care? Have we
Right.
made the proper referrals to help them to kind of coordinate what needs to happen? And so we really do have a lot of work to do with this understanding that you pop the baby out and everything is fine. As a
Mhm.
matter of fact, the research now shows that if a mom has a hypertensive disorder of pregnancy, the architecture of the heart has changed, and
Yep.
her risk of cardiovascular disease for her lifetime is now different, which means we got to be looking at our grandmas and asking them, did you have preeclampsia when you were pregnant? Because that's going to impact what we do in terms of referring them to cardiology. And
I
so I
was
want
going
to
to
make
ask that.
sure that
Yeah.
we're not just focused on the immediate postpartum, yes, but pregnancy is an opportunity. For a lot of women, it's the only time they have insurance, unfortunately. And we now have that postpartum extension. But we need to utilize and optimize that access to care. They need to go to the dentist and make sure their teeth are clean. They need to be going to see the cardiologist if they had a hypertensive disorder. If they need cardiac rehab, we need to be doing that. If they are overweight, and we need to access special medication and nutrition to help them bring their weight down before the next pregnancy. So that year is prime time for what we can do to help our moms. And I think it's important for people to understand that the risk doesn't magically disappear after 6 weeks,
Right.
because we're losing our mamas for that entire time.
Can you? So I was one of those labels that you don't want to put on. I had my children at 39 and 42. Mhm.
Mm.
Elderly gravida, I think is
Geriatric.
geriatric in ICD in the ICD. But
Mhm.
true, statistics. Here we go. A Black educated woman, right? Someone speak to and compare a Black educated woman who you would think she's more educated, she's eating well, she's probably living on the right side, of 285, if you will. She's doing what she knows is all the right things, but her outcomes are worse than our counterparts, a white woman with an eighth grade education. Could you speak to that? Don't
Oh,
scare the people, but just educate the people.
that's my soapbox right there because
So,
I'm in my 40s, okay? And as a Black woman who's still in the childbearing age, um, you look at that and you think about all the things that we were told to do: go to school, get an education, get a good career, move to the best neighborhood you can afford, and find the right partner and get married. You do all the things you're told to do. It might take us a little longer, right? And then we're older and we're finally getting ready to have babies. But that is the highest risk group for Black women. It's those of us who are highly educated, you have a college degree or higher, you have you have higher socioeconomic status, access to what we would call the best care, um, and and you think about people who are so accomplished, like Dr. Irving and Kira Johnson, and these were folks who had worked hard to build their lives, right? And
Right.
then now they want to get married and they want to have kids, and so when you think about these types of outcomes, you realize that there is very little that protects us. But you know what protects us? Being having um, a village around us, having access to doula care for those of us who are not higher risk, being cared for by a midwife. Cultural congruent care has also
Mm,
been scientifically proven to help Black moms and babies.
right.
So there's so much that's happening with that to unpack that. But you got to think about. I was having a really good conversation with a colleague. And she was saying, there's a lot of stress that comes with being the first few or only.
Mm.
And you have to
First
think
few are
about,
only. Wow.
right. So, you're the only Black woman in your class. You're the only Black woman at your hospital. You're the only Black woman in leadership roles. There's a lot of stress to maintain that, right? And so that also leads to weathering.
Mm-hmm.
So, that group that's 40 and up is actually the highest risk group.
Mm-hmm.
But
Mm-hmm.
I want to add that what you said it, Joy, fierce advocacy.
Yes.
I get text messages all the time. My friend is at the hospital. This is what's going on. Tell me what you think. And I don't ever want to contradict what another clinician is doing, but I can say, this is what I think, or and just people not being prepared. I'll give you one simple example. I had a friend who she went in, she got an epidural, but then baby was not progressing, and so the epidural stopped working, and the options were, did they do a spinal, or did they redose the epidural, or did they put her to sleep? And she was not sure what to do. And I thought, okay, well, let's work through that. But that's the first time. First of all, you're in pain and you're distressed and you're trying to make a major decision. That's not the right time to do that.
Mhm.
But, thinking about, again, what we do in advance to prepare for if this, then that. And so we want our moms not to be surprised by all of those things. And I do agree with you, but advocacy is where it happens. And so we get to do that officially as OBGYNs, but we also do it a lot peripherally because we have to step in and help people to advocate. And so I think that the way that's making it, and that's why I think the doula care perspective and that really helps, because that advocacy and that voice gets to be elevated in a way that it might not have been before. But we do have a lot of patients that have good outcomes. Joy, I know you have them. I know you've had them. I mean, you see something going down and you get the team. And
Right.
so I really want our audience to also realize that I don't want my mamas to have to leave Georgia to have a baby. Okay. It's just a matter of doing that research and finding the right person to really help that,
Mhm.
but also being able to advocate for yourself. And if you are have an interaction with someone who is not listening to you, then you got to find somebody else to
Yeah.
listen to.
Mhm. We talk
And
a
so
lot
I
about
think
the chain of communication
mhm,
um,
really,
in my
really
clinic,
important. Yeah.
and one of the things that kind of surprised me was like patients would come in and we would say, okay, well, we're 39 weeks. Do you want to see if you're dilating at all? And do you want to be checked? No, I went to the hospital and it was terrible. And so I always have a conversation and I say, if you feel it's the it's like the exam is too rough, feel comfortable to say, hey, would you mind just being a little bit more gentle with me? If you feel like you're not heard or you're not on the same page with the person who is spending time, because our labor and delivery nurses spend a lot of time with those patients, and the doctors may be in and out every few hours. And I'll say, talk to the charge nurse if you feel like you and your nurse are not, first it's okay to say, I'm not sure you're hearing me. And then escalate from there. So you knowing that, hey, the chain of command is my nurse, my charge nurse. And then there is, if it's a problem with the physician, there's always a department chair
Mm-hmm.
or a medical director. And then there's also an administrator on call. So there are many channels where
Mhm.
you can, find ways to be
Mhm.
heard if you're having
Absolutely.
trouble with that.
And so that also goes back to choosing appropriately an OB care team that you feel comfortable with, that you can have conversations with, right? And I remember my nurses on labor and delivery used to say, your patients don't come in like I said, I educate a lot.
Hmm.
I take time and prepare. Okay, you're 28 weeks. Let me tell you what to expect now that you're entering into your third trimester. I educated the mess out of my patients, so they already knew. And then I would tell you this too, as far as relationships, one thing that I do miss, and people will ask me here and there, do I miss delivering babies? And I said, this is what I miss, because this is what I know about me. I built trust and I build relationships. And I would tell my patients when I'm doing their strep test, right, at 36 weeks about, I would say, now let's talk about this delivery process. First of all, who you inviting into that room? I would get into her business. Like, if you don't really care for your mother-in-law, that ain't the time for you to be trying to, no. And if your auntie gets on your last nerves, or she's squeamish, or all she wants to do is convince you why you shouldn't have an epidural, girl, I had all my babies natural. Choose who's going to be in the room. Are they someone who just wants to tell their own birthing story and be in your ear all the time? or there's someone who's going to stop and say, "Excuse me, what is that bag you're hanging?" Or what's that beeping mean? Right? Not to
Mm-hmm.
aggravate the team, but to question. So I would always encourage my mom's pregnant folks about that. Like I would tell them what to expect. And then the other thing that I was very good at, one of the only few things that I miss is, okay, let's have this talk. I know you have this, what do we, oh, birthing plans, right? I know you got this 5-page birthing plan. Let me explain something to you. One of the best compliments Dr. Jew has ever gotten was that I was the closest to a midwife type of doctor that this midwife had ever seen. I said, I'm really good. But if I get in your face and I say, we need to roll to the operating room, trust and believe it's time. And I had built that relationship with my patients, and a patient reminded me of that the other recently. She came back to see me and she goes, "You got my face and you said we got to roll." And I said, "Well, I meant that, didn't I?" And so building relationships. And I think you mentioned it earlier, Dr. Keisha, in my previous practice, I started, what do we call it? A meet and greet, because the
Mhm.
practice was so large. I think we had like 5 obstetricians, 3 midwives at the time. And the average woman gets about 12 to 13 visits. So to make certain that you met everyone, we paired with the hospital if they were going on a tour on that, whatever night it was, Tuesday night. An hour before, we held a meet and greet in the hospital. Whatever we can do on our end, I think is vitally important to build those relationships and those bonds with our patients. And then you um, encourage your loved ones who are pregnant or are planning to be, to build relationship as best as you can. It's important. So I have a question as we are about to wrap it up. Our hour is coming to a close. Why, I've heard this a lot this week during Black Maternal Health Week. Why do we need to move from just talking about surviving to thriving in maternal health? And what does thriving actually look like? I want to hear from both.
Joy, you want to go first?
Hey, I, you know, it because that's what we deserve, right? Like, why are we just? I had a patient that said this to me, and it really struck me like almost dumb. Like, we were in the room, and I was asking her, "Tell me how you envision your birth." And all she did, she looked me straight in my eyes. She said, "I just don't want to die." And I thought to I mean, it almost literally brought me to tears. And I was like, what do you mean? Like, you haven't thought about, I want you to put my baby on my chest and I want to put him in
Right,
this outfit.
right.
Like, no, all she was wanting was just to
To
survive.
live.
And,
Yeah.
and I was like, this should not be. We should have the opportunity to greet our birth with anticipation and with joy and, have the things laid out how we want to do. And I want the dad to cut the cord and I want to do whatever, skin to skin. And that was what I was thinking she was going to say to me. She
Right.
was just like, just don't let me die, you know and that is the bare minimum. Quality and safety for every woman every time is the bare minimum, right? We ought to be
Yeah.
able to provide that secret sauce of safety, quality, and experience. Your
Yeah.
birth should be something lovely. I had another patient who, we started building relationship very early on, and she was very, closed up and kind of aggressive. And she said she wanted to interview me, and it was all fear because
Yeah.
she was worried about, like, am I going to make it out? And so we built this lovely relationship, and her partner was just the coolest. Like, he's massaging feet and feeding her chocolate covered strawberries, and then when it's time for her to push, she had an epidural and she was numb. And when I tell you, that lady literally laughed her baby into the world, she was laughing and the head came out, and it was one of the most beautiful births that I've
Hmm.
ever seen.
Hmm.
And I think about that a lot. I'm like, that's what every woman, every birthing person deserves. Is,
Exactly.
And
Yeah.
I'm
Yeah.
gonna take it from there and talk about how we step into the postpartum period. Okay, so a lot of times we're so focused on that pregnancy and birth, which is appropriate. It's 9 months, almost 10. But then you have a new life to take care of, and you've also got to take care of yourself in a way that you can be there for that mom, for that child. I'm sorry. And so what I want to when I think about thriving, the other part of or the chapter in the book is making sure that your postpartum period is also reasonable. You don't feel right in your privates, so how do we work on that? You might be
Mhm.
constipated. How do we work on that? What does your nutrition look like? Are you taking your prenatal vitamins? Do you need pelvic floor therapy? Do you need help with breastfeeding? Do you need help with contraception? How are we going to manage your sleep? How are we going to manage your mood? There are like all these things that really need to come together so you can thrive, even though that cute little baby that hollers all night is keeping you up. You should still just feel like I am so happy that I have the privilege to have that opportunity. And so I think that what has happened is we focus so much on the pregnancy that we have not planned for life after, what happens beyond the birth. And that
Mhm.
is where we can really help our patients to thrive because
Mhm.
the rubber meets the road. Stuff happens, and sometimes it doesn't happen the way that we plan, but that can also still be beautiful. And that can be an experience for you and your family and your support system. But it also just doesn't need to happen to chance. And I think a lot of times we put so much in the birth, and we have the reveal, and we have the shower, and we have the diapers. But there's so much more to what happens after that that I
Right.
want us to step into. What happens to your lochia? It's going to be red, then it's going to be brown, then it's going to be yellow. You're not dying, you're
Right.
fine. The breast
Right.
getting engorged, get some cabbage leaves. I mean, we could work through that. But I think we want our moms to really embrace all of the challenges and joys that come with childbirth, but we have to
Yeah.
put some intention into how we prepare for that.
And also
Absolutely.
just making, you know, in my role as director for quality and safety, I want to make sure that there's a safe space, creating a safe space. Can we dismantle all the systems that we have in this country? Probably not in our lifetime. But while we navigate these systems that were not necessarily built for us as Black women, we need some people who are willing to speak up. Now, if someone has a heart problem, in terms of how they feel about the patients they're taking care of, and there was a really interesting study that I could talk about. We won't have time, but just like how people perceive some of the patients that they're caring for. We can't change that, right? Necessarily. Can't change how you feel about me when you look at me. But what I can and will do is hold you accountable
Mhm.
for whether or not you did, you provided the standard of care and
Yeah.
you did your best for that patient. And so I think that's what we have to do. And that's why I love the theme this year, Rooted in Justice. We're making sure that every woman, every time we do the right thing, but
Right.
also enjoy, because joy is a part of resistance. Deciding that, all these statistics and all these things people are saying, and the news, the news channels are running wild with all these horrible things that are going to happen to Black women. I think we cannot allow that um, to cause us to live in fear when it comes to our birthing.
And that thank you for sharing that and saying that because there's a joy that we want them to have, even the experience. I used to have one of my other memories, fond memories. I would never prepare the dads, but at the last minute, I would say, Dad, you want to catch the baby? Oh my God, come on, help me, help me. I never prepared them because they're going to back out if I did that. I would go, what size? Let me see your hands. Get them up size 8 gloves, and they would deliver their own babies, of course, with my guidance. I miss that. Not enough to go back in the OB, though. We are about to wrap it up. I wanted to share a few more numbers only because I love your sharing about the doula care that goes beyond just the birthing room for these birthing people. But statistics, CDC quotes it a lot that nearly 700 women die a year, but that 80% of cases are thought to be preventable. 80%. So we don't want you to think it's all doom and gloom and that you gotta find you a Black female doctor. Like, that'd be great. But congruency, what you call it, culturally congruent care is important and may be necessary for you. But I also want to not forget those near misses. CDC also shares that maybe for every one maternal death, there are somewhere between 70 and 100 near misses. And those women live with some trauma too.
Mhm.
And we want them to thrive in their next pregnancies. We don't want them to say, well, I'm one and done because of what happened the other year. We want to give them a safe space and a safe place. And even I, as a GYN only physician, oftentimes I sit my patients down and discuss what the prior pregnancy or deliveries, plural, look like, and ask her, are you done? And many times we're met with a little, trepidation or, and I said, well, let's talk about it. And then let me refer you, because the maternal fetal medicine specialist oftentimes will see those folks for consultation. Let's talk about you having a history of lupus in pregnancy, or having had that hemorrhage that you needed to run back to the OR the day of your delivery, which was so traumatic for you. Let's have these discussions and let me refer you to the appropriate people to help navigate this. I definitely want you to realize, all of you who have joined us, that this is not a journey that we want you to navigate alone. You have support. Find your team, not just your sister girlfriend, but find your team. I want to thank Dr. Joy. I want to thank Dr. Keisha for joining us. If you have anything you want to share, let me not stop you, but I'm going to end on that. And thank you all for joining us. Please do share GSMA-Med. Please like us, follow us, go back and watch some of our prior episodes, but please take us out if you have any last thoughts you'd like to share.
So I'm just going to end with a quote that I love, that I think is very important for all of the justice work that we're doing, Joy, that you talked about. And it says, if a flower doesn't bloom, you don't fix the flower, you fix the environment in which the flower grows. And that is our responsibility. Every day that we wake up, whether or not we're doing OB-GYN, however that works, our job is to really make sure the environment allows our patients to thrive, not just be focused on survival. And so however we can do that, in educating our dads, our partners, the community, the people at the grocery store, people who drive the bus, everybody needs to be on that team so we can help our moms experience the joy. I need a K word because I keep hearing joy and I'm like, joy and joy, Jew. I don't have anything with a K. I want to work on that. But I think that it's not unreasonable. I think the vision board that women have for a healthy pregnancy is achievable, and we should not stop and we should not rest until we achieve that environment to help our women thrive.
Thank you.
Absolutely. I couldn't have said it better myself. I can't go after Keisha's quote. So I'll just wish everyone a good night.
All right, thank you. See you next time.
Bye. Thank you, Dr. Drew. Thank you, Dr.
Bye.
Joy.
Thank you so much for
Thank
having
you.
us.
The content shared on this podcast is for informational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. The views expressed by our guest and host are their own and do not necessarily reflect the official positions of GSMA. At GSMA, we stand on over 130 years of medical excellence and advocacy, but we encourage you to always consult your physician or qualified health provider with any questions you may have regarding a medical condition. If you think you may have a medical emergency, call your doctor or 911 immediately. Until next time, stay informed, stay empowered, and stay well.